Hello, everybody, and welcome. My name is Megan O'Leary, and as the Director for Marketing for Sisu Healthcare IT Solutions, I'd like to welcome you to our latest webinar. Meaningful use is a hot topic these days, as well it should be. So many of our smaller rural clients are working with tight budgets and are looking for any opportunity to cut costs and increase both revenue and profits. Meaningful use, which presents either the opportunity for valuable reimbursements or costly penalties, can really impact these facilities' budgets, so it's understandable that so many of these facilities have their eyes glued to this topic. Plus, the sheer complexity of the rules governing incentives and the way these rules shift from year to year can make it easy to overlook requirements. That's why we at Sisu are lucky to have Mark Sandvick on board as our Director of Meaningful Use. Mark has been with Sisu since its inception in 1997 and has over 20 years of healthcare IT experience. He's held the position of Meaningful Use Director since 2009, providing guidance to more than a dozen mostly rural customers as they strive to meet the many objectives that pertain to meaningful use. Today, Mark is going to do an overview of the most commonly overlooked items that may get in the way of your facility attesting to meaningful use now and into the future. And just a quick housekeeping note before I turn it over to Mark. We'll be holding a Q&A session at the end of the presentation, so if you have any questions, please feel free to type them into the questions box that you'll see on the right-hand side of your screen in the little gray box. I'll get as many as I can to Mark in the time we have allotted for today at Q&A at the end of the presentation. And now I'd like to turn it over to Mark Sandvick.
Thank you, Megan, and thank you, everyone, for taking the time to join me today. My intent is to bring to your attention some of what you should be focused on as you look back at your 2015 Meaningful Use Attestation, assess your readiness to attest in this current program year, 2016, and you look forward to attesting hopefully in 2017, 2018, and beyond. Now, in my opinion, everything I discuss is something that you should not put off. You need to be thinking about these items now and not 6 or 12 months from now. And while many of the examples I discussed today pertain to the eligible hospital critical access hospital EHR incentive programs, there are many similar examples on the eligible professional side. So the thoughts and ideas shared today are applicable to all. It's important to me that you do not leave this presentation thinking it's only applicable to hospitals and critical access hospitals. And then lastly, some of you may be questioning, well, why talk about program year 2017 and 2018 when we haven't even reached the midway point of 2016? And really for me, it's, you know, if you wait until 2017 or 2018 to think about what will be required to achieve meaningful use, it's going to be too late. So your greatest chance of success is to get ahead of the curve. Now the slide you're looking at here is basically a slide showing today's agenda. I'd like to start out by just talking briefly about 2015 and wrapping up last year's attestation, then transitioning to a bit of discussion surrounding 2016 or the current program year, and bringing to your attention some potential obstacles or challenges in attesting this year and how you might be able to overcome those to ensure your greatest chance of success. We'll also talk quite a bit about 2017 meaningful use and what may be expected and some of the challenges you might face. And then we'll even look as far ahead as 2018, which, while it seems a bit off in the distance, it's just around the corner from a meaningful use perspective. So first, let's move on and look at wrapping up 2015. And if we advance to the next slide, what I'm about to cover, while I am specifically speaking to you from a 2015 wrap-up perspective, much of what I share is applicable regardless of the program year. So on the next slide, the first thing I would recommend you do, if you have not done this already, is assess your readiness for a post-attestation audit. And a good place to start is reviewing the CMS supporting documentation for audits fact sheet. And there will be a file you'll receive after, or a link to a file you'll receive at the conclusion of this presentation, I think about an hour after it concludes, which will include a link to the supporting documentation that I am referring to today. This document summarizes the information that CMS would recommend you retain in the event of an audit. I want to remind you that if you are in fact picked or selected to go through a post-attestation audit, you have 4 weeks or less to respond to that request. And if you think about that, that means you should have your attestation supporting documentation completed, well organized, and easily accessible. And then keep in mind as well that your documentation should be retained for up to 6 years. Now I want to talk a little bit about making sure your audit documentation is complete, organized, and accessible. Obviously, if you do receive notice that you're going to be audited, it's going to be a stressful situation. I have had I don't know if you would say fortunate or unfortunate, I've been through 3 of them with some of my customers. And they are a stressful situation because of the reduced amount of time you have to respond. So we have found the greatest chance of success and to reduce our stress is to ensure that we have our documentation or our ducks in a row prior to receiving that notice of an audit. You also want to ensure that it's well organized so that you can find the information necessary to respond to the questions that are posed by the auditors. And when it comes to accessibility, for most of the organizations, if not all of the organizations I work with, they are small, rural, critical access hospitals. And typically there is 1, maybe 2 individuals who own meaningful use at the facility. And that individual may be responsible for monitoring the ongoing progress for the facility. They're responsible for attesting to meaningful use on behalf of the facility, and they're responsible for gathering and retaining and organizing the documentation. And oftentimes, or in some instances, this documentation may be kept in an individual's personal file folder. And it may be kept electronically, it may be kept on paper, or in some organizations they like to do both. Well, if you're thinking in the electronic world, it's important to me that you understand, or multiple individuals, pardon me, within your facility, understand where that documentation resides. So in the event the individual who is primarily responsible for gathering that documentation, should they be unavailable, perhaps they move on to a different position within or outside of the organization, or perhaps they just have some time off, if the request comes in through for an audit, there'll be other individuals within your facility who have an awareness of where that information is located and can go about responding to the audit request in the event the person who originally gathered it is unavailable. Additionally, while it's not noted here on this particular slide, you'll of course want to ensure that wherever that information is stored at your organization, it is well secured, because it quite likely could contain PHI. And you'll also want to ensure that it is backed up, especially if it is kept electronically. Make sure you check with your IT department to ensure that folder, wherever those documents are stored, are being backed up, so in the event that you have any type of catastrophe, you'll be able to restore those documents at a later date. Also, if we move on here and wrapping up 2016, another thing I would recommend is you monitor the status of your 2015 attestation submission. Check periodically throughout this current program year to see how last year's attestation is progressing. And what you're seeing on screen here is a screenshot from the Medicare CMS EHR registration and attestation screening. And I have highlighted a couple of areas that I'd like you to key on. The first area shows the status of both your Medicare and, if applicable, Medicaid payment. And why it's important that you monitor this throughout the year is your ability to attest for the current program is dependent on the prior program year having been completed successfully. And I actually ran into this with several of the customers I worked with, where in past years they went to attest to meaningful use, only to discover that their prior year attestation hadn't been completed by CMS, and then they were unable to attest until that issue was resolved. Now, as most all of you know, we have roughly 60 days from the end of the program year to attest to meaningful use. And that's typically, and at least is what we experienced this year and what we expect next year, is we'll have basically from January 1st until the end of February of 2017 to attest for program year 2016. And for most of us, I'm guessing you don't attempt to attest to meaningful use on January 1st. A lot of you might wait till the second, third week in January. Some may even wait until February to log into the website and submit your attestation information. Well, now envision if your 2015 attestation wasn't completed properly by CMS and you discover that you cannot attest for 2016. Now you're having to reach out to CMS, you're having to try to resolve this issue, get it resolved, and then go ahead and finish your 2016 attestation all by the end of February of 2017. So by proactively logging into this website at various points throughout the program year of 2016 and checking on the status of your 2015 attestation, you can lessen the possibility of having errors when you go, or issues when you go to attest early next year. My recommendation would be, if come, say, fall, let's just say August, September timeframe, if you do not see any indication that your payment or your incentive has been completed, that is when I would start reaching out to CMS or your Medicare intermediary to try to determine why it hasn't been completed and ensure that it is completed so that you have no unexpected surprises come attestation time in January, February of next year. The other area I want to bring to your attention is in the lower right where it says business address. I don't know how well you can see that. It has been redacted to protect the facility whose screenshot this came from. But a couple of things I have experienced with some other customers, and this may or may not be applicable to you. I've had a couple of facilities that have built, were lucky enough to build new facilities, and they have relocated. Yet the business address on this particular page reflected the address of their old facility, so you'd want to ensure that is up to date and accurate. And then the last item I want to point out is the line that shows email, and that is typically the email address of the primary contact regarding meaningful use at your particular facility. And you would want to ensure that that is a valid email address and actually points to an email address that exists and is being actively monitored. And here's where I had a situation again where I've had a couple of individuals I've worked with over the years that have moved on to different positions within the organization or have left their organization. Yet this particular email address was still referencing that individual's name, and no one was monitoring or receiving the emails. So any notifications being generated by CMS out of this system weren't being received by anybody. So you'd want to check on that and update it if necessary. Moving on the next screen here, something to think about as well is probably a common theme you'll hear from me today: don't make assumptions. It's important that you monitor for penalties. So for most all of us, I'm guessing on the line, we attest to meaningful use. We complete our submission to CMS, and then we sit back and we may assume that we are going to not be penalized or that we will receive some type of incentive payment. And I was having a conversation with Erica, who is a vice president of analytics here at Sisu. And Erica has an extensive background in revenue cycle management. And Erica is really helping me close the loop here with respect to meaningful use and the penalties and incentive side of it. And I asked Erica in a conversation I had with her if she could provide me some recommendations as to what a hospital and eligible professional should be looking for with respect to penalties and incentives. And she recommended that first off you look at your 835 electronic remittances. And without going into a great depth here, you can just read the screen. There was recommendations that you do not make an assumption that you are not receiving penalties. And in fact, Erica has been working with one of our customers who has attested to meaningful use not only for program year 2015, but several years prior to that. Yet she uncovered in reviewing their 835 electronic remittance that they were receiving some type of penalty based on meaningful use. And she has been working with the facility to establish why is this penalty coming through, given the fact that we have documentation that said you have successfully attested to meaningful use. So in summary, a successful attestation does not guarantee that penalties will not be assessed, and therefore you should take the time to determine if penalties or ensure that penalties are not being applied. Similarly, on the next slide, you can see here that you should also, if expected, be monitoring to receive incentives. Now, most of the incentives have gone away now, unless you're participating in the Medicaid program within your particular state. But if you are expecting some form of remittance related to attesting to meaningful use, once again, it's better to be proactive and ensure that you did receive the incentive that you are expecting. If we take up now, if that can do so, let's move on to year 2016 and what I think you should be doing right now. And I think a good starting point to help you ensure you have success in program year 2016 is to start by educating yourself. First off, don't assume your EHR vendor will lead you there. That is not to say you should not take advantage of any educational opportunities provided by your EHR vendor. I'm simply stating just don't be completely reliant on they're going to tell you what to do. Keep in mind your EHR vendor works with probably thousands of customers across this country of varying size and types, and therefore I think it falls upon you to have a better understanding of how meaningful use impacts you and what you should be doing. One source of education surrounding meaningful use in the past has been the National Regional Extension Program, or REC program. Now, it is my understanding that the Regional Extension Program, at least the national program, ended on April 7th. And I believe, don't quote me here, but I believe many of the regional extension centers across this country have ceased to exist as a result of the loss of funding or have severely cut back on their services. So I believe they are less and less a group that you can go to receive this education. Short of reading the final rule, which was released in early October of last year, this rule, which of course is several hundred pages in length, is obviously the best source of education on meaningful use, but is probably not realistic for the vast majority of you that you can take the time to read this multi-hundred page rule. So one area I would recommend you go to is, and you actually can see it on the screenshot here in the upper left-hand corner, is you can go to the CMS EHR Incentive Program website's homepage. And from that homepage, I don't know how well you can see it, but on the left-hand side there's a number of selections, and one of them is titled the 2016 Program Requirements. And if you click on that link, it actually brings up the screen that you see in the lower right. And this is an excellent source of information surrounding the 2016 program year. But like this entire website as a whole, there is so much information that it can be a bit overwhelming. But if you do elect to use this to educate yourself, be prepared to do a lot of reading. If we move to the next slide, just a bit about, well, what exactly is on this 2016 Program Requirements webpage. Well, it's a good source for specification sheets from CMS that are applicable to each of the eligible professional, eligible hospital, and critical access hospital. It has information regarding alternate exclusions that are applicable in 2016. It has overviews of changes to specific objectives in 2016. There's information on the 2016 EHR reporting period, which as of today we believe to be a full calendar year for any of us beyond our first year of meaningful use. They also have checklists applicable to registration and attestation of meaningful use in program year 2016. And there are numerous objectives specific tip sheets that are also available. I would recommend you take time to read everything found on this page. The way I handle it for my customers is I take on the burden of reading this information and then informing my customers of those pieces of information on this website that I believe impacts them and what they need to be aware of. So I'm trying to take the burden off of them of having to read everything on here and trying to understand if it impacts them. And instead I take on that burden and try to educate them. A key thing to keep in mind with respect to 2016 is don't assume what you did in 2015 to attest to meaningful use will suffice in 2016. Now, even though you may be attesting to modified stage 2, again in program 2016, in program year 2016, what you do may differ in 2015. So let's take a look at several examples to help illustrate these potential pitfalls or obstacles to attesting to meaningful use. On this particular slide, on the left you're going to see a screenshot that reflects the 2015 CMS Clinical Decision Support Specification Sheet. And then on the right-hand side, you're seeing the 2016 Clinical Decision Support Specification Sheet. Now the yellow and tan highlighted areas on the screenshot on the left reflect an alternative objective and an alternative measure that was available in 2015. But as you can see, if you look to the right, it's no longer available in 2016. So you need to determine if you took advantage of this alternative objective and measure in 2015. If you did, confirm that you do not intend to take advantage of it again in 2016 because it's no longer applicable. Let's take a look at another example. Now in this particular example, once again on the left-hand side we have an excerpt from a CMS specification sheet, this time surrounding CPOE, and it's a 2015 specification sheet. And on the right we have the 2016 specification sheet. The highlighted area on the left reflects an alternative measure or alternate measure that was available in 2015 that is no longer available in 2016. So once again, you'd want to read this, determine if you took advantage of this alternative measure in 2015, and if you did, confirm you once again do not intend to take advantage of it in 2016 because once again, this alternative measure is no longer applicable. So again, trying to highlight that just because you attested to meaningful use last year does not guarantee you are well positioned to attest this year. It's worth the time to take right now to look into this just to make sure you don't get hit with any sudden surprises when you go to attest next year. A third example on the next slide. In this particular case, once again, we're looking at an excerpt from the 2016 CPOE specification sheet. And I want you to note the highlighted areas in the lower left. And some of you might be reading this saying, it says providers scheduled to be in stage 1 in 2016. And you may be asking yourself, oh, wait a second here now. I thought this whole concept of stage 1 and stage 2 of meaningful use went away. Aren't we all attesting to modified stage 2 now going forward? And while that is true, CMS does offer alternative exclusion or alternate exclusions to those who, under the old stage 2 rule, would have been scheduled to attest to stage 1 in 2016. So then the next logical question is, well, how do I determine if I would have been scheduled to attest to stage 1 in 2016, therefore these alternate exclusions are possibly applicable to me? Now, a simple way for me to help you understand that is under the old program, if you have never attested or you attested last year to meaningful use for the first time, then you would have been scheduled to attest to Stage 1 in 2016, and thus the alternate exclusions would be applicable to you. If you attested for the first time to meaningful use in 2014 or any prior year, you would have not been scheduled to attest to Stage 1 in 2016, and thus this alternate exclusion would not be applicable to you. And then if we take a look at a fourth and final example here that I'll try to illustrate. With the new rule that came out in early October of last year and was finalized, CMS removed or eliminated redundant, duplicate, and topped-out objectives. And I'm showing you here on slide, if we advance it, a partial list of some of the objectives that CMS eliminated. Now, this could be construed to mean that there is no longer an importance in capturing this information related to these eliminated objectives. But in reality, the capturing of this information is still critical to achieving meaningful use. And I'm going to try to illustrate that to you on the following slide. Now, one of the objectives that was not eliminated was known as health information exchange. It used to be known as, and many of you probably still refer to it, I do, as the summary of care objective or the transition of care objective. It's been renamed health information exchange under the new rule. This particular objective requires a summary of care document be used to meet the objective. And CMS defines what information needs to be included in a summary of care document. Now, the items listed in red on the screen here reflect some of the information that should be included in the summary of care document. These same items also reflect redundant, duplicate, and topped-out objectives that have been eliminated. So while no longer reported or measured, many redundant, duplicate, and topped-out objectives are still critical to meeting meaningful use objectives that remain. Now, on the next slide, I'd like to review with you some of what I think you should be tracking with respect to the 2016 program year. Now, first off, I would recommend that you monitor on a regular basis throughout the program year how well you are doing at meeting the various meaningful use objectives and how you are proceeding in meeting those. I would say in a perfect world, if this is realistic, I would like to see you running your reports and checking how well you're doing on a weekly basis. I recognize the fact that at a number of these small facilities, the person who is responsible for meaningful use may wear multiple hats within the facility, and they have other responsibilities beyond meaningful use. So monitoring on a weekly basis may be more difficult than I would expect. What I have done with my customers is we have quarterly meetings to ensure that at least a quarterly basis we're talking meaningful use. While I do recommend to my customers that they run their reports and monitor their progress on a weekly basis, I would say your frequency be no more than at least a month between running reports. And why I am so emphatic about running these reports on a regular frequency is to ensure that obviously if you are failing to meet a particular measure, the sooner you recognize the fact that you are failing to meet a particular measure, the more time you have to react and address that measure and get your threshold or your percentages back up such that you can ensure you're meeting your threshold. And then my last recommendation with respect to tracking progress is that if you do discover that you are not meeting a particular measure, you do not wait to raise the red flag. In other words, that you immediately bring this to the attention of hopefully a group of individuals at your facility that are helping you address your facility's progress in meeting meaningful use. Perhaps you bring it to your administration. Do whatever you need to ensure that discussion is surrounding your failure to meet that particular objective, and that you potentially have a game plan associated to how you will react and ensure that you can meet that objective by the end of the program year. A couple of other things to think about with respect to your 2016 attestation progress. Don't wait to review your audit needs. Review multiple times throughout the year what information you may need to gather to support your 2016 attestation. For those of you who went through this before, I'm sure you can envision some of the recommendations from CMS surrounding the capturing of screenshots and recommending that many of these screenshots be captured during the reporting period, not after or before the reporting period. So it's important that you ensure that you are capturing those applicable screenshots during your reporting period. And the way I've recommended and how some of my customers have gotten around this is, or reminded themselves, they have actually scheduled time once or twice, maybe 3 times on their calendar throughout the year to just remind themselves that they need to set aside a few hours to go through this attestation checklist and ensure that they're capturing the appropriate information in the appropriate time frame. So once again, if you wait until after the end of the program year, so basically early 2017, to start thinking about what documentation you need to capture to support your 2016 attestation, it may be too late in some cases. And then the last item I have, I think it's on the next slide here, thank you, is the security risk analysis, which I think all of you recognize the fact in order to meet the objectives surrounding protecting patient health information, you must on an annual basis refresh your security risk analysis and mitigate any gaps that were identified. I find at a lot of these smaller hospitals that nobody really wants to take ownership in this. It's usually a group effort because there's probably not an individual at the facility who's been designated as a security officer, or if they are designated as a security officer, once again, it's just one of the roles that they fulfill at the particular facility. So I'm just stressing again the importance that you schedule or start your security risk analysis. When it comes to scheduling or when it comes to the risk analysis, I recognize that many of you have opted to refresh the security risk analysis in-house using hospital or clinic resources. Some of you elect to outsource this to a company that specializes in this. Either way, it's important that you get something on your calendar. The sooner the better. And if you are going to leverage or are considering leveraging a third-party vendor to achieve this, that you reach out to that third-party vendor and make sure that you get on their radar screen so you can ensure the security risk analysis occurs within a timely manner. Because keep in mind, once the security risk analysis is complete, it will likely identify gaps that must be mitigated, and you must complete those by the end of the program year. So the sooner you get going on your security risk analysis, the sooner that it gets accomplished, the more time you're allotted within your organization to react to any gaps that have been identified. And then I think the final item I'd like to talk to with respect to tracking your 2016 progress is to make sure you get actively engaged, as I put it, in public health reporting. Now, when the final rule was released last October surrounding this whole modified Stage 2 and what we'll have to do to attest to Stage 3 of meaningful use, I believe CMS tried to simplify public health reporting with the new rule. And what they did is they combined several objectives into one objective labeled public health reporting. So they took the objectives you used to know as of immunization reporting to public health agencies, lab test result reporting, cancer registry reporting, syndromic surveillance reporting to state public health agencies. They combined those into a single objective. And I think it was the idea here was to simplify public health reporting and how you would meet that particular objective. But in my personal opinion, based on the number of FAQs that CMS has released and the number of tip sheets they have also released, it seems since October, I'm not quite sure they have succeeded in making this any easier. So once again, educating yourself on the public health objective, what must be done to meet the objective. The sooner you start that process, the better off you are in ensuring that you have a game plan on how you will meet this. So let's move on to 2017, and while the 2017 program year does not start until next January, there is plenty for us to be thinking about or doing between now and January 1st. So the first thing I want to talk about here is a little disclaimer. I put together this presentation in early April, and that was prior to when the Department of Health and Human Services issued two new proposed rules in late April. One was a proposed rule to implement key provisions of the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA. And then they also released a second proposed rule surrounding the Inpatient Prospective Payment System, or IPPS rule. The proposed MACRA rule will likely impact everyone to some degree, and it will be felt as early as January 1st of next year, and even sooner if you consider the modifications necessary to meet what is being proposed in the rule. The IPPS rule will impact eligible hospitals and critical access hospitals, and will be felt as early as January 1st of next year as well, and once again, sooner if you consider the modifications needed to support the proposed rule. And I'll touch on those briefly in the coming slides here. Well, I guess we actually have one of those slides up. It's important that I get across to you with respect to both of these rules, so the Inpatient Prospective Payment proposed rule, as well as the MACRA rule. Do not ignore either rule. It's important that you educate or receive education on those two rules. So what I want to first take a look at here, and maybe this slide is a bit out of order here. Well, we will, let's go back to that slide, Megan, that you were on. And, oh, well, it's just a bit out here. Well, I'll just go through it. First of all, holy MACRA. MACRA, once again, short for Medicare Access and CHIP Reauthorization Act of 2015. CHIP is short for Children's Health Insurance Program. The actual MACRA rule was signed into law a year ago this past April, and it's bipartisan legislation that replaced the flawed sustainable growth rate formula with a new approach for paying clinicians for value and quality of care that they provide. Now, in late April of this year, the Department of Health and Human Services issued a proposed rule to implement the MACRA changes that were finalized in the rule from a year ago. The proposed rule that was released this April is currently in its comment period, and I have noted it is in a comment period until June 27th. The rule is expected to be finalized by November 1st of this year, but its impact could be felt as soon as January 1st of this year. So not a heck of a lot of time, as usual, from our federal government from the time they finalize something they propose to the time it actually has an impact to you as a healthcare provider. And the MACRA rule proposes replacing Medicare EHR incentive program for physicians, or the EP part of the program. Now, it's important for me, and what I wanted to bring forth on this, let me just make sure I get this right. Oh, I think I'll skip over that. If we can slide on to the next slide here. The next rule I wanted to talk about is the Inpatient Prospective Payment. I'm sorry, I'm just moving around on my slides here. This is the second proposed rule that was released in late April that has an impact on meaningful use in 2017. So some history here regarding this. In the 2015 EHR Incentive Program final rule, that's the rule that was finalized last October. I often refer to it as the Modified Stage 2 rule, or the Stage 3 rule. CMS noted within that rule that they would address clinical quality measure reporting requirements for both the Medicare and Medicaid EHR incentive program for eligible hospitals and critical access hospitals for program years 2016, 2017, and future years, that they would propose or they would identify reporting requirements in the inpatient prospective payment systems rulemaking. So just to kind of highlight this, in the past, when we would look at the meaningful use rules, within the rules it would identify what clinical quality measures we would have to select from in order to attest to meaningful use. But with the newest rule last October, they said, we're not going to address clinical quality measure reporting in this rule. Instead, we're going to point you to this inpatient prospective payment system, and that will explain to you what you need to do quality measure reporting going forward as it pertains to meaningful use for eligible hospitals and critical access hospitals. Similarly, they said when it comes for the eligible professional program, we're instead going to point to the Medicare physician fee schedule rulemaking, which also establishes requirements for PQRS and other quality programs affecting eligible professionals. So we knew, based on the rule last October, that this was coming, and it came in April. And it is making some suggestions to how and what you will report with respect to quality measures surrounding meaningful use in program year 2017. As stated, the rule was released on April 27th. A portion of the rule covers clinical quality measurements for eligible hospitals and critical access hospitals. And what it defines is any new program requirements, what are the reporting requirements surrounding CQMs in 2017, what the reporting and submission periods are, what methods you can do to actually submit quality measures to CMS, and it provides other information regarding the clinical quality measures. What's important to note, I've been reading through this particular rule, which once again is several hundred pages in length. It does not propose to add any new clinical quality measures in 2017. And if I can speak specifically to hospitals and critical access hospitals, you may recall that you have currently 29 clinical quality measures to choose from, of which you are required to report 16. Unless you are electronically reporting in 2016, then you can choose as few as 4. The proposed rule does propose to reduce the number of available CQMs by 13 from the original list of 29. So we had 29 to start with. They are proposing eliminating 13 of those, which leaves 16. And we are still expected to report 16 going forward in 2017. So my understanding would be we're all going to be reporting the same 16 clinical quality measures starting in 2017, at least on the eligible hospital and critical access hospital side, if the proposed rule is finalized as it is currently written. And once again, the final rule, this particular rule, won't be finalized until August, yet it will take effect in January. So we really won't know what we have to do with respect to clinical quality measure reporting until August of this year, yet it won't take effect, yet it takes effect as soon as January. So for the hospitals I am working with, we're probably going to move forward right now with some assumptions regarding this proposed rule rather than waiting for it to be finalized and not allowing us enough time to react to those changes. I think the next slide here, Megan, if you move on, just to give you an idea here, these are the 15 clinical quality measures that CMS is proposing be eliminated out of the original list of 29. So if you happen to know what quality measures you are reporting today, you might get a rough idea of how this rule might impact you, and that you might recognize the fact there may be one or more quality measures that you're currently reporting and will report in 2016 that may not be valid come 2017. If we move on here, some other 2017 considerations to be thinking about. First off, the first bullet point is, start thinking about 2017 now. Don't wait until 2017 to think about 2017. And hopefully some of those prior slides in these new rules at least had you start thinking that, yeah, we got to be thinking about 2017 right now. It's a ways out, but it's definitely going to have an impact on us, and we need to start learning more about that. You need to start identifying changes specific to the 2017 program. It's important that you stay informed. Once again, if you were to go out to the CMS website, EHR Incentive Program website, on the left-hand side there is a link that says 2017 Program Requirements. If you were to click on that link, you can find more information specific to the 2017 program reporting requirements. I will warn you that if you look there today, there is very little information available. I would expect at some point this year, hopefully sooner rather than later, CMS will update that and include much more information similar to the type of content it surrounds or it provides surrounding the 2016 program year. So right now, if you're interested in learning about the 2017 program requirements, you're pretty well limited to reaching out to other resources such as myself, perhaps your Regional Extension Center program, or if you're so inclined, call up the rule that was finalized last October and start reading through it. And then I think the last item I would recommend, or one thing I want to recommend too, just on that CMS website, there is a way for you to sign up to receive notifications via email when CMS has updated that website. So rather than having to go out and proactively check from time to time to see if content has been published, you can be informed via email when CMS has posted content. I will warn you that I have had mixed results with subscribing to automatic updates from that site, but it is worth at least trying and then checking from time to time. And then the last item I have on the screen here is contemplate how you will approach attestation in 2017. And one thing I failed to mention earlier, and probably most of you are aware of, in program year 2017, you can once again attest to modified stage 2 of meaningful use, or you can optionally report for the first time on stage 3 of meaningful use. Now, if you elect to report to modified stage 2 in program year 2017, you must do so right now, at least we're being told, for the entire calendar year of 2017. If you elect to instead attest to stage 3 of meaningful use for the first time, you can do so for any 90-day period of time that falls within the 2017 calendar year. One important item to note, and we'll touch on this a little bit more when we talk about 2018, is if you do plan to attest to stage 3 of meaningful use, whether you choose to do so optionally in 2017 or when it becomes required in 2018, you must be utilizing 2015 certified EHR technology. And I am going to guess and go out on a limb here that everybody on the phone today is currently using 2014 certified EHR technology and not 2015 certified EHR technology. Although I am pretty sure, although I'll talk about this, that your EHR vendor is actively planning how they will upgrade your EHR solution to meet the 2015 standards and certification requirements. If we move on to the next slide here, I want to transition and talk a little bit about 2018. And granted, 2018 is, a year and a half away. But you have to keep in mind, come 2018, we are being told we have to attest to stage 3 of meaningful use. There is no other option. It's going to have to be stage 3 of meaningful use, and we are going to have to do so for the entire program year or calendar year of 2018. Now, as in the past, there's always the possibility that CMS will issue some type of exemption where they might reduce the reporting period, as they did in 2014 and 2015, to something less than a year. But at this particular time, we have to have the mindset, as we have this year and next year, that we must attest for the entire program year. And again, this is making the assumption that you're beyond your first year of meaningful use. As I stated just a moment ago, Stage 3 will require the upgrading or the implementation of 2015 certified EHR technology. Likely, your transition to 2015 certified EHR technology will take place this year or next. If your EHR vendor or vendors, especially if you use multiple EHR solutions to attest to meaningful use, if they have not provided you an idea of when they will transition you to 2015 certified EHR technology, you need to be asking them right now. You need to get on the phone with them and ask them for what their game plan is to get you there. You need to know your EHR vendor has a plan, and then they can get you there, and when they plan to get you there. Now, with one of the EHR vendors that I interact with quite a bit, I have been reaching out to them on behalf of my customer base, and they have indicated that they do plan to certify their software to the 2015 standards, and that their plan is to deliver and upgrade customers to the meaningful use compliant version of their software either towards the end of this year or early next year. And while we don't have exact dates at this particular time, I'm at least being led to believe, and I'm getting good information from that EHR vendor, that they do have a plan for getting me there. If my EHR vendor had turned around and said, we haven't really thought about that yet, we're not quite sure what we're going to do, I think I would have a little bit of concern, because if you think about it, 2018 is only around the corner from that perspective of having to implement and take an upgrade to get you there. If we move on to the next slide, some other things to start thinking about in 2018. 2017, you're going to spend a lot of time implementing solutions needed in 2018. So besides requiring the increased adoption of existing EHR technology, Stage 3 will likely require adoption of new EHR technology to meet certain objectives and measures that you maybe don't have to meet today to attest to meaningful use. You should consider the hardware, staff time, education, and labor needed to support the adoption of both 2015 certified EHR technology and new EHR technology required by Stage 3 of meaningful use. And while you may not choose to attest to Stage 3 until 2018, the technology needed will be implemented in 2017. So start considering the impact to your 2017 budget cycles. And I'm guessing many of you may be in the midst of a capital budget cycle or have a budget cycle coming up in the fall, and you need to be thinking about what is that software, what are those additional items I'm going to need in order to position my facility to attest to meaningful use in Stage 3 come 2018, because those are purchases that are going to have to be made in 2017 and implemented in 2017. And then also, if you have not done so already, as I do for my customers, reach out to your EHR vendor now and try to start gaining an understanding from them what is needed or what might be needed, and do your best to include some items in the budget. And then on my final slide here, just some final thoughts to kind of summarize what I discussed in the past 55 minutes. Take some time to review the past, to review your 2015 attestation to make sure you have your ducks in a row. Please don't become complacent due to past success. I can be subject to that, and I'm sure you as well. If things are going well, we sometimes assume they will go well in the future. Don't make assumptions. Think beyond the present. In other words, be thinking about 2017 meaningful use as well as 2018. And if nothing else, I hope today's presentation will make you question how well you are prepared going forward and what challenges and obstacles you may face as you continue to address the EHR incentive program, or what you might refer to, and I often refer to, as meaningful use. And with that, I think I will hand it over to Megan to see if there are any questions.
Great. Thank you so much, Mark. And I just want to reinforce that Mark pointed out a number of really helpful online resources. And about an hour after the webinar, you'll get an email from our system that'll give you a link to a PDF that contains links to all of the resources that Mark mentioned today. So please do keep your eye out on your email for that PDF. I do have a couple questions for you, Mark, that came from the audience. So our first question comes from Kim. And she wanted to talk a little bit, ask a question about the screenshots that you mentioned for documentation. How often would you say it's important to capture these screenshots? Weekly, monthly? Do you have a guideline you give your customers?
Well, what I have hospitals is my belief is that you capture the screenshots once and as long as it's within the reporting period, which currently, the 2016 reporting period or program year runs from January 1st of this year through December 31st of this year. Now, if that program year or reporting period is reduced to something less than an entire calendar year, such as 90 days, well then obviously your screenshot has to be within that 90-day time frame. I know some organizations that I have talked to in the past, they capture these screenshots at numerous instances throughout the year. They might do them as often as monthly. I personally don't understand why that is necessary. I'm not necessarily convinced that screenshots prove anything, but with that said, if CMS says you should capture screenshots, then by all means capture screenshots, but I would just argue I don't know what they prove. So as far as frequency, in my opinion, if you capture them once and in the proper time frame, you are okay. But obviously, you as the organization, you are the one who will attest to meaningful use. You are the one who will face the audit. So you should capture them in whatever frequency you are the most comfortable with. And if that's every month, every week, twice a year, you do whatever you feel comfortable for. But I would say at a minimum once, obviously.
Great, thank you. I have another question here from Janet, who had a question about the security risk analysis you mentioned earlier. She asked, is this something we do once a year or we do once and refresh every year? Can you talk a little bit about how often that takes place?
Yes, CMS does offer a nice tip sheet on the security risk analysis because I think it is an area that a number of organizations struggle with. It is most certainly something that an auditor will ask for if you are asked or do participate in an audit or are picked to participate in an audit. So I can't stress enough the importance of doing a security risk analysis. CMS now clearly states that your risk analysis must be refreshed annually. So you must do it once a year. It must be started on or after the start of your report or the program year or reporting year, which in this case is January 1st, and then it must be completed before the end of, I believe they say your attestation time frame, but what I say is you start it and you ensure it is completed, including mitigation of any gaps that have been identified by the end of the calendar year. So you only have to do it once. There may be some stipulation surrounding, well, what happens if I switch EHR vendors in the midst of a program year? So part of the year I'm under EHR vendor A, part of the year I'm under EHR vendor B. In that particular case, I'd want to go look a little closer and do some research because there may be some logic as to, well, when is the appropriate time to do the risk analysis? Should I do it twice, once when I am using both each of the vendor solutions, or can I just do it once and it can encompass both solutions? Hopefully that answers the question.
Great, thank you. I have one final question from David, who asked if you could clarify by what date these facilities need to be on 2015 certified EHR technology.
You would need to be on 2015 certified EHR technology prior to starting your stage 3 meaningful use. And this is where it gets a bit tricky here. The way I approach this is, let's say you elect to attest to meaningful use stage 3, and you're going to wait and not start until January 1st of 2018. Then my approach and recommendation is by January 1st of 2018, obviously way sooner than that, you have in place and you are utilizing 2015 certified EHR technology. Now, if you are someone who is going to opt to try to attest to meaningful use stage 3 for 90 days in 2017, then you would need to have 2015 technology in place prior to the start of that 90-day attestation period. Why I say it gets a bit complicated, there are some FAQs that CMS has released where they indicate that in some instances you do not need to possess this technology, the EHR technology, at the start of the reporting period. You can possess it at any time throughout the reporting period. Yet in the next breath, they'll say there are instances where it is required that you have the technology at the start of the reporting period. Let me try to illustrate that. Take, for example, clinical decision support. The requirement is that you have enabled clinical decision support from day 1 of the start of your reporting period till the end of your reporting period. That requires that you have the EHR technology in place necessary to meet that objective on day 1 of your reporting period. But now let's take a look at, for example, e-prescribing. Now, e-prescribing has a threshold of, I think it's 10% on the hospital side. Let's say you don't currently have e-prescribing technology in place at your particular facility. If you can implement the technology this year, and you can utilize the technology such that you can exceed the 10% threshold, you can still meet the objective this year, even though you didn't have e-prescribing and technology in place on January 1st or at the start of the reporting period. So there's these exceptions to the rule, and that's why I've approached it with my customers to say, let's take the lowest common denominator or the worst case scenario, and let's make sure we have that technology in place on day 1. If there is anything that might jeopardize our ability to achieve that, then let's take that on a case-by-case scenario and see if we have any flexibility that will allow us not to have that technology in place on day 1.
Great. Thank you so much, Mark. I really appreciate it. Well, we hope today's webinar has given you some new insights and helped you avoid some common meaningful use mistakes. If we can answer any questions about attesting to meaningful use at your facility, please do get in touch with us. I'd like you to reach out to Kevin McArdle. He's our Chief Revenue Officer, and he's the one who will help pair you up with the right Sisu expert. And if you're lucky, you'll get Mark. So thank you, Mark, so much for sharing your expertise. Or I know we have a couple of Mark's customers on the line, so you have Mark's contact information, and you can get in touch with him directly. Again, thank you so much for joining us today. Thank you, Mark, for your time, and we hope to speak to you again soon. Bye-bye.